In case you guys didn't know me, because I don't recognize all the faces, I know Ann, but my name's Karen Willis. I'm the parish nurse here at Covenant. So if you have any questions about programming, health, wellness stuff going on here, I can direct you to the right place. So, and I welcome Doug
Oh,
to
thank you.
join us tonight. It sounds like you guys all know each other, obviously. But I'm really interested to hear your whole story.
Oh, good,
So-
yeah.
So if we have technical issues, I can help troubleshoot as well.
Doug Robinson, I told you, retired endocrinologist. I'm gonna talk to you tonight about medical debt, but since it's just a small group here and Frank and Connie and my wife Inez know, this is a gateway to a larger conversation about healthcare in the United States and the brokenness of our healthcare system. That's pretty apropos right now with all the things that are coming down the line, and another 16 million people will be without health insurance in the United States in the next decade. But this is a kind of a gateway conversation to that larger conversation.
There's Gwen.
Hey.
Hey,
Can you
Gwen.
hear us, Gwen?
Hey, Gwen, can you see us? We can hear you. Oh, great.
First, I just want to mention my organizations. I'm the chair of Healthcare Justice North Carolina. We're one of 3 chapters in North Carolina, chapters of Physicians for a National Health Program. PNHP is about 25,000 members, physicians, other healthcare professionals, healthcare advocates, and we and lay people, and we're advocates for universal single payer healthcare in the United States, a national healthcare program.
Right?
So there's the QR code there. So before I dig into the statistics, because they can get a little dry there at the beginning, I want to humanize this story for you. This is Terry Belk. He's a local fellow who dealt with medical debt over a number of years and finally had it relieved and is doing fine now, but he went through quite a struggle being pursued for medical debt. So let me just.
You want me to put you over to his story?
Oh, hold on, I just can't double click. So now
No,
what do
I
do?
changed it. Hang on, to make it easier for you. Let's see where I am. Hang on a second. It is this one, Terry. All you have to do is click the picture and it'll start playing.
And these people still came at me and her as she would die for money. For money we didn't have. Not saying we didn't owe it,
There we go.
but it should have been a better way to collect it than what they were doing. This is a national crisis. This is not just affecting North Carolina. This is nationwide, and hopefully this becomes a movement. My late wife was diagnosed with breast cancer in 2003. We had private health insurance, but it wasn't adequate to cover all the bills. So we were shocked a few months down the road, we get this big gigantic bill from the medical providers saying that we owed $23,000 that the insurance company didn't pay. About a month and a half, we get these letters and phone calls from their attorney threatening to take us to court, to sue us, put a judgment on us and all of that. She said, why are they doing this to us? To us, that was a lot of money, but to them, I'm sure it was pennies. And several months later, she subsequently passed. Fast forward, in 2010, I was diagnosed with prostate cancer. I had private health insurance there again, and it wasn't adequate to cover all the bills. I'm paying on the prostate cancer bill, and I am probably going to take this debt into the afterlife. The only way that this is going to stop is people speak up, speak out, and advocate for better. I'm in this because I lost love of my life. And I feel her spirit with me every day, and I know that she wants me to stay in this fight, and I will.
that stopped doing that when Terry's story got on NBC National News. And then they announced that they were not going to continue to pursue the lien on his home.
Weren't they just pressured at the very last medical system to cave in North Carolina?
Yes,
Them
them and Duke.
they are a particularly rapacious group.
So, when I watch that, I have a number of thoughts, and some of them are visceral. What kind of country do we live in where in the midst of suffering and illness, you're also hounded for medical debt and to pay the hospital bills from the illness you have? And the thing I want you to notice about Terry's story, we'll get to this later, he has health insurance. He had health insurance that whole time. And it wasn't adequate. And, now before I drill down on some more statistics, since this is a church presentation, I always like to zoom out and look at what our faith tells us about what healthcare should be like in this country. And we all know that Jesus's ministry was one of compassion and healing. And in fact, many of us as Christians believe that healthcare should be a fundamental human right. Almost every wealthy industrialized nation views and treats healthcare as a human right. And most of them have implemented universal healthcare. Western medicine really developed as an expression of Christian charity, and medical care also played a significant role in the growth of the early church. The Christian duty to care for the sick and the poor led to the earliest hospitals, which were charity hospitals. They offered care regardless of class or social status. And in fact, I changed this for each church I go to talk at. This used to say Episcopal, and before that it said Methodist, but now it says Presbyterian. All these major churches have made statements about how they envision healthcare should be for the United States. Now, this is 2008. Presbyterian Church advocated for a single-payer universal national health insurance program that best responds to the moral imperative of the gospel. And we believe there is a moral imperative there. I love this quote. This is from clerk of the Presbyterian Church General Assembly. As followers of our great physician Jesus, we have a moral imperative to work to assure that everyone has full access to health care. Last, I want to introduce the concept to you of, you may not have heard of before, and it's called moral injury. Now, you probably all know what burnout means for practicing physician healthcare providers. We get burnout because of long hours, lots of patients, the electronic medical record. Moral injury is different than that. Moral injury is knowing what you need to do for your patient as a physician or a healthcare provider, but not being able to do it because of forces beyond your control. Be that the insurance company or the patient's lack of insurance or inability to pay. This causes moral injury to the provider, and providers go through this every day with delays of care, denials of care. I'll give you an example from my practice. I was a diabetes doctor for many years. A couple of times a year, folks with diabetes can develop diabetic eye disease that is more or less an emergency at the time. So I'll have a patient come in and say, "Doc, I got a black spot in my left eye, I can't see." I'd take a look in their eyes, they'd be bleeding. And I'd want to get them to their ophthalmologist as soon as possible. I'd tell my nurse to make an appointment, and she'd come back and say, they won't see them because they have an outstanding medical bill. Once that's paid, they'll see them.
Wow.
So I have a patient in front of me who's going blind, but can't get into the doctor because they have an outstanding medical debt.
It's appalling.
That's moral injury. That's when your patient's in front of you, you're in the wealthiest nation in the world, and you can't do what's right for your patient. Cumulative effect of moral injury, along with burnout, means more and more physicians are leaving the practice of medicine because of this. Oops, maybe there we go. Okay, time for some statistics. Wouldn't be a healthcare justice talk without some statistics. They're a little shocking, a little shameful. 100 million Americans have medical debt. Cumulatively, we owe about $220 billion. A lot of us over $1,000 and still a lot of us over $10,000. And we borrow to pay off our medical debt. 31 million borrowed 74 billion. And this is shocking. Half of adults can't pay a $500 medical bill without going into debt. 20% of North Carolina residents have medical debt collections in 2022. That's the fourth highest in the country. Has a lot of other statistics I'll show you here tonight. You guessed it. This is worse for people of color. That percent goes up to about 25% for people of color in North Carolina. And you'll hear that time again in this talk. So there's consequences to medical debt beyond the financial. People have worse physical and mental health. They'll skip or postpone care. 21% of them don't fill prescriptions. And often your patients, you know this, your patients won't tell you when they go to they don't fill the prescription because there's shame involved. But you know the scenario. You go into CVS and the lady behind the counter looks at the computer and looks up at you and says, "Did they tell you how much this would cost?" And they tell you. Well, a lot of folks just walk out. They don't fill those prescriptions when they have medical debt. They have difficulty paying other bills and affording basic necessities. It's the number one cause of bankruptcy in the United States. And it's the largest source of debt and collections and damages credit scores when it really shouldn't. We'll talk about that later. This is just some of the personal sacrifices. You could have guessed this. People cut back on spending, savings. They take on extra work. They delay education. They do what they got to do. When they got medical debt, it has tremendous downstream consequences in our society. So this is an interesting, this study. This is Duke Law and North Carolina Treasurer in 2023. They looked at North Carolina hospitals suing patients between 2017 and 2022. And I'm showing you this, not for any statistics right now. I just want to show you some quotes from the folks who had legal judgments against them. What it does to a person emotionally from anxiety and stress, it aggravates my illness. Makes you scared to even go to the doctor. We went through everything to get help on those bills, and they said no. It was a judgment for $192,000. So this is in North Carolina. Who has the most medical debt? Who had these judgments against them? So there's medical debt judgments in our county, 2008 through 2022. I don't know if you're all are aware of the concept of the crescent and the wedge. Mm-hmm. So it's kind of a 20th century demographic where Charlotte was admittedly more racially and economically segregated then, but the wedge was more wealthy or whiter, kind of South Charlotte, Myers Parky, and the crescent were more people of color and low income. So who had the medical debt judgments against them? You guessed it. People of color, low income folks had more medical debt judgments against them. So we pile on. So again, who has medical debt? You guessed it. Young adults, Black, Hispanic adults, and women. Women are all more likely to borrow for health expenses. And we're seeing something now that people do GoFundMe pages to pay for their medical care in America. Most medical debt is hospital incurred. A lot of it is in Southern Medicaid non-expansion states. Fortunately, North Carolina is no longer among them. Low income persons with families, people with poor health or disability. And of course, the 30 million people in the United States who are uninsured have medical debt. Yeah, half of those is an important, because we often think, well, they have medical debt because they don't have insurance. I'm good, I got insurance. Half those with medical debt have health insurance. Why is that? As you'll see, as we talk later, you all know this, our medical insurance only offers partial coverage. You have high deductibles. The deductible on a bronze ACA marketplace plan, something north of $7,000. So you're not insured until you pay that $7,000. It resets every year. So health insurance is far from comprehensive. You know, this is one group I want to focus on for a second. It's kind of shocking. You know, childbirth should be a joyful time, you know, for a family, and yet it results in medical debt for a huge number of people. 12% of people have some medical debt due to pregnancy or childbirth, and having a baby doubles your risk of medical debt. Folks, even with health insurance, leave the hospital with a bill of about $3,000. And if the child ends up in the ICU, you get about $5,000 out-of-pocket costs. So what do these young families do? Decrease spending on food, clothing, other essentials. They delay buying that home. They delay going back to school. Tremendous downstream economic consequences of this. So let's do another personal story here. This is also on NBC News. Click again. And this is about a young family with medical debt.
Hang on a second. I'm getting there. She's behind here. If I can get to her tab. Oh, there it is. That's her.
It's pretty psychedelic.
Yeah, I don't know how that got.
Why do you have a spoon?
At nearly 2, Jessica Hurley's twin boys are as old as the debt that accompanied their births. The Springfield, Illinois toddlers arrived 2 months early, Kinzer naturally and Perry via emergency C-section, only to begin a harrowing weeks-long stay in the neonatal intensive care unit.
They were hooked up to machines, and multiple times they would turn blue in my arms and their hearts were essentially stopping.
So, your babies are in the NICU, you're dealing with this trauma, and then you start getting the bills.
Then they just kept coming. He's about to drive up.
A dental hygienist and career laborer, Jessica and her husband Jimmy have insurance through his union. These are all your bills.
Yes.
This one's for $5,200. This one's for $2,200.
Go sit at your table, guys.
But their plan caps out-of-pocket costs at $28,500 per calendar year. The twins were born in late December, resetting that cap on January 1st and leaving the couple on the hook to meet it twice. Their account balance topping $80,000 after insurance.
I do find that this comes as a surprise for patients.
Dr. Nora Becker, a health economist with the University of Michigan, says the Hurleys, who have 4 children total, were swept into a growing trend among middle-class American families who make too much money to qualify for Medicaid, relying on private, often employer-provided insurance with increasingly high deductibles. And while most Americans with insurance through their jobs pay around $3,600 out of pocket for childbirth-related costs, data analyzed by the Healthcare Cost Institute shows for about a quarter of those Americans, childbirth costs $5,000 or more.
This is how private health insurance works for everybody. It's just that low and middle income families are the ones who bear the brunt of it.
Her advice to families expecting, check your plan beforehand and consider switching to options with lower deductibles, even if the monthly premium is higher. And if you get hit with big bills, don't ignore them. Negotiate. Jessica did, and nearly 2 years later managed to whittle her family's debt down to roughly $11,500, more than a quarter of which they've paid.
And a quiet old lady who was whispering, hush.
The remaining debt prompting Jessica to avoid seeking treatment for postpartum depression, fearing more bills.
Financially, it's ruined us. And all that happened to me was I had babies. Izzy, go inside.
The cost of living hitting this family hard right from the start. Maggie Vespa, NBC News, Springfield, Illinois.
Thanks for watching. Stay updated about...
Yeah, just pause that one and flip back.
So I'll just digress here for a minute. This concept, another oddball concept in the American healthcare system of deductibles and premiums and copays and co-insurance. In the industry, they call this having skin in the game. In other words, you have to pay a portion of your healthcare out of fear, some healthcare economists think, that if you didn't have to do that, you'd be overusing the system. You'd be going to the doctor or all the time. Like we enjoy doing it. In actuality, all the skin in the game, co-pays, deductibles, is limit the healthcare that people get. So saves insurance companies money. Insurance companies make a lot of money from it, but all it does is end up denying healthcare to people. The skin in the game concept. So why do we have medical debt? Well, as I said, no insurance or underinsurance, the cost of healthcare, pay 2 or 3 times as much in the United States for prescription drugs. We talked about lack of comprehensive coverage, high deductibles and premiums. And
Sorry.
Insurance denials of care, delays of care. You remember the delays and denials of care, or the peer-to-peer phone calls you had to make to get it paid. Billing errors and insurance complexity. Insurance is really complex in the United States. And just remember, the bills are fraught with errors. So if you get a bill you think is wrong, make sure you review it before you pay it. About 1,000 health insurance companies in the United States. Of course, there's 5 or 10 very large ones. This means hospitals and doctors' office has to have a lot of people to manage the billing complexity. So I'll just tell you a funny statistic and see if you can guess the answer to this. So first of all, there's about 10 administrators for every physician in the United States due to the complexity of our healthcare system. 10 administrators. So you take the Duke healthcare system down the road, about 1,000-bed healthcare system. They have 1,600 billing clerks to handle the complexity of billing. Now, the University of Toronto, Canadian National Healthcare System, has about 1,300 beds, a little bit bigger. Guess how many billing clerks they have at the University of Toronto?
10.
What?
10?
Oh, that's really good. It's 7. But
I just took it.
7 instead of 1,600.
That's insane.
So, maybe we're a little overly complex here.
And they have national health.
Yeah.
Yeah. So why do we have medical debt in America? It is a symptom of a larger disease. And we're going to pivot now and talk about the disease, or the elephant in the room. And that's our broken American healthcare system. In America, half of adults say it's difficult to afford care costs. As I said, about 20% of us don't fill our prescriptions. A lot of folks cut pills or skip doses. I want to be clear, our American healthcare system is exceptional in a lot of ways. Technology, innovation, cutting edge treatments are the best in the world. But there's a lot that contributes to the brokenness of our healthcare system. Some would say it's expensive, complicated, dysfunctional. We are the only wealthy nation in the world without universal healthcare. Yet we have the costliest healthcare in the world by 2-fold. And we have some of the worst outcomes. Maternal mortality, particularly for Black women. Again, all these statistics, worse for people of color. Maternal mortality, infant mortality, lifespan, all worse in America than similar wealthy countries in the world. We do this weird thing in America where we treat healthcare like a market commodity, like gasoline or eggs. Like you're really going to go out and comparison shop. You're having that heart attack and you kind of look up the hospital like, where can I get that thromboplasty the cheapest? Nobody does that. There's no transparency. People don't comparison shop when they're having a heart attack or a stroke. We do this other weird thing that's unique to the United States. We link our healthcare to employment, so that if you lose your job, you lose your healthcare. That stifles entrepreneurism, so the guy stays at his job at Starbucks rather than going out and starting his own coffee shop. And then finally, sounds stark, but lack of health insurance kills people. 45,000 of us are estimated to die each year due to lack of health insurance. I just want to put this in the context of, and I'm not going to talk about this a lot tonight, but with forthcoming Medicaid cuts and loss of the ACA premium tax credits, about 16 million people are going to become uninsured in the United States. Some of them will die due to lack of health insurance in the wealthiest country in the world. Then we do this other funny thing. Medical school is expensive, and so not many people go into primary care anymore. So we focus on disease treatment rather than prevention in the United States. We get a little cattywampus upside down. So we need more primary care physicians. But it's hard to pay off those expensive medical school bills with that. Okay, so this is a graph of healthcare spending as a percent of GDP in the United States compared to healthcare outcomes, including access to care, equity, and health outcomes. And you can see the poor old United States is right down there. We spend a ton of our percent of GDP, and yet our health outcomes are the worst of wealthy industrialized nations. Another graph. So about 56% of us are fully insured. About 9% of us, 27 million, are uninsured. 12% have what's called a coverage gap, where you may have insurance part of the year. And that's all well and good if you're perfectly healthy. But if you have a chronic disease, like the people with diabetes I saw, if you have type 1 diabetes, suddenly can't get affordable insulin, that's a problem. If you're being treated for cancer and you lose your insurance, that's a problem. So a gap in healthcare coverage can be deadly. Now, I really want you to focus on this group up here. This is the underinsured.
Doug, what's OOP cost?
Out of pocket.
Oh,
So this is the academic definition of underinsured. You have out-of-pocket costs. Now, this is not including premiums. When they talk about out-of-pocket costs, we're not talking about premiums. But when your out-of-pocket costs are greater than 10% of your household income, or your deductible is more than 5% of your household income, many states on average with employer-based insurance meet that. People struggle to afford healthcare even if they have employer-based insurance. So 2/3 of people who are underinsured have employer-sponsored insurance plans. 2/3. So underinsured. Interesting about the ACA, about 20 million people got insurance with the ACA. It was wonderful. So we got more insured, less uninsured, more insured, but we also increased the underinsured. Again, these plans are expensive. That's why you need premium tax credits and enhanced premium tax credits to afford them. And then even with that, there's no discussion about how high the deductibles are, but the deductibles on ACA plans are pretty robust. So like I said, on a bronze plan, you can be up around $7,000 or $8,000 before you get any care. And like the poor woman in the video, if that happens in December, it resets in January and you got to pay another.
Yeah.
It is perverse.
Yeah.
So this is just a few more statistics here. I won't belabor. This is employer-sponsored insurance policy in North Carolina. These are pretty much like the national average. Now the national employer-based deductible is about $1,700, and that's increased about 50% in the last 10 years. And then a family premiums average is in North Carolina $7,000 with the deductible $4,000. So what do these folks do when they're underinsured? They avoid necessary medical care, they have worsening health, and they collect medical debt. Inability to pay for care is increasing, particularly for Hispanic and Black adults in low-income households. It's on the increase, 6% from 2021.
I'm not sure what that is, but there's programming upstairs.
Where does our money go? Well, total healthcare spending, about 4.3 trillion, again, about 18% of GDP. A lot of it goes to administrative spending. About $1 trillion goes to administrative overhead and profit for our health insurance industry. Insurance companies, hospital billing staff, physician office staff. 65% of us have private health insurance provided by for-profit insurance companies. Some people say our healthcare system is broken. Others say, no, it's working just like it was designed. That is the way it was designed, is that most of us would get our health care from for-profit insurance companies. All right, now this is a video, but this is a key video. Can we make this one
Oh,
work?
we need a key bit.
Oh, come on.
I'll do it.
Oh,
Who's doing well?
Bueller?
No, give me a second, 'cause
Sorry.
it takes a minute to get these.
Sorry, Doug.
Who is doing well despite rising healthcare costs?
I think we got it. Give it a minute.
Anyone?
Oh,
It's supposed to be on a loop, but anyone?
Anyone?
Who's doing well?
Anyone?
Of course we know who's doing well. These are 2022 statistics, so even bigger numbers are being thrown up now. The big five health insurance companies and total CEO compensation in the millions.
No, in the hundreds of millions.
Yes. And insurance profits are just outpacing national healthcare expenditures. It's big business in the United States. So, whoa,
hang on. I can't get that in.
you can't get back to normal?
That is as small as it was going.
Okay. So this is to say, we're fed up in America. So opinion of US healthcare and quality of coverage is an all-time low for life. So you ask people about quality of healthcare in the country, healthcare coverage in the country. Opinions of that are at a 20-year low. We saw that after the unfortunate murder of Brian Thompson, the CEO of United Healthcare, last year. At a time when people should have been mourning his death, a lot of people spoke out about United Healthcare in particular, and how they tend to put profits over patient care. There are some solutions out there I want to talk about for a bit. There are federal solutions, state solutions, hospital systems are doing better, what individuals can do, and then I want to talk about some nonprofits. First of all, let me just amaze you with my AI generated slide here that has a little running medical bill and a little bad debt crying. So this takes you through, and I've got a little crazy. This is what AI and coffee will do when you're making slides. So anyway, just focus on the circle. So once a bill isn't paid, it becomes bad debt. Then the hospital system, and to be clear, most debt is hospital incurred debt. Hospital can sell it to a debt buyer, typically for about a penny on the dollar, or they'll continue to try collecting it, or they'll just warehouse it. After a certain period of time, and the big three credit reporting agencies decided on this, is if you have debt over $500, it's in collections for a year, it will end up on your credit report. Now, this is an important point. Does medical debt belong on a credit report? No, it does in no way indicates or is an indicator of your credit worthiness, unlike credit card debt or that type of thing. Medical debt is due to surprise expenses, ones they don't plan for. So it really has no business on your credit report. Once it's on your credit report, it interferes with your ability to get a home mortgage, small business loan, etc. So it's really toxic stuff. Let's talk about the federal policies. The 2025, the Consumer Financial Protection Board was going to have a rule that banned the inclusion of medical bills and credit report of medical debt. Well, the current administration, that was vacated by a federal court in Texas. So as it stands right now, in most states, medical debt will end up on your credit report. Some states have had state rulings against that. 2022 No Surprises Act. This is for these unexpected out-of-network bills. So the scenario is you're sick, you go to the ER is in your network, but the ER doctor's not in your network. So you get the surprise bill because he's not in your network. You get hospitalized, it's great, it's in a hospital, it's in your network. You get an x-ray, but the radiologist's not in your network. So this kind of shenanigans. So that's not allowed anymore. No Surprises Act covered that. If you do not have health insurance, you're entitled to a good faith estimate. Of course, all of us think everybody should get a good faith estimate, but this is at least some strides in that direction. If you don't have insurance, you're entitled to one. The ACA, so there's a lot of nonprofit or not-for-profits in the hospitals in the United States. There's thousands of them. But the Affordable Care Act required them to be more accountable for the way they handle medical debt and to create and implement a written financial assistance policy. It's not always the easiest for patients to find out what that policy is or have access to debt relief through these hospitals. But now the ACA required them to do that. Have they done it? Not all so well. So state policies, they've strengthened financial assistance requirements for hospitals. They're holding nonprofit hospitals accountable for their tax exempt status by asking them to demonstrate their community benefit investments like financial assistance. Some hospitals are partnering with nonprofits like Undo Medical Debt to buy and cancel medical debt. You saw that it's available for a penny on the dollar. You can buy up medical debt. We'll talk about that in a minute. And states are strengthening consumer protections. And then this last one is a real pat on the back for the state of North Carolina. And a big thank you to Governor Roy Cooper and his Secretary of Health and Human Services during his administration. He came up with this unique way of using excess Medicaid payments to entice hospitals to relieve medical debt and develop financial assistance programs. So when we expanded Medicaid in North Carolina, that was a good thing, very good thing, but some hospitals needed a little extra financial assistance to help them afford to take care of Medicaid patients. And those are called, getting deep in the weeds here, those are called HASP funds. So we got extra money from the government. And one way the state of North Carolina got the okay to use that from CMS is to use that to pay hospitals to relieve medical debt. This is not a law, this is a program. It's currently still in force, but it would be wonderful if it was in some type of law. So there's three parts in it there: to relieve existing medical debt, prevent new medical debt, and protect us from unfair debt collection practices. There's a lot here. I don't want to belabor all this. But July of this year, hospitals have to relieve medical debt or donate all unpaid medical debt going back to January 2014. Why did they choose January 2014? That's when the ACA implemented Medicaid expansion. And North Carolina didn't do that until 2023. So a bunch of people got into medical debt during that decade. Shouldn't have. And this is a way to make up for that by relieving their medical debt. So that's where 2014 comes. Okay. Next year, hospitals are going to relieve all uncollectible medical debt back to 2014. Patients won't have any tax liability for debt relief, and the hospitals have to set up payment plans. So I'm not going to get into the weeds of this, but it's all good stuff. So there's discounts on medical bills based on federal poverty levels. So people will get discounts.
Is this new? Because I thought originally that one of the big, stumbling blocks was that at least some of the systems wouldn't.
Well, they all pretty much, every
consider
major hospital in North Carolina signed up for it. 90-some hospitals, now Duke and Atrium were the last.
Yes.
Yeah.
They
Kinda went
kicking and
After
screaming.
Novant did
Well,
it.
I had heard that.
So,
Yeah.
that is part of it.
And-
So,
and they're considered nonprofit and worthy of that status.
so discounts have to be applied to the amount the patients owed. In the past, hospitals were allowed to charge interest of about 8 or 9% on their medical debt. Now it's limited to 3%. And again, payment plans. And then it's going to eliminate all these bad collection practices. They're going to sell debt, selling debt to third parties with income up to 300% of the federal poverty level, unless it's for debt relief. Etc. So they're gonna end a lot of problematic debt collection process. So let me just give Atrium a little pat on the back here. That was Atrium. that was pursuing Terry Belt for his debt, and that decided to, now called Advocate Health, decided to no longer place liens on hospitals in September 2024. Not liens on people's property. So even before that, Atrium was starting to pull back on their debt collection practices. So they've done some good things. In case I ever want to go back to work there, I wanted to tell them. Yeah, love you, Adrian. So, all right. So this is important. What can patients do? You got to really do your due discipline on this. Get familiar with your insurance coverage and out-of-pocket costs. Watch out for these facility fees. This happened to my white wife the other day. Is hospitals, even at facilities that are not in the hospital but are related to the hospital, even if they're miles away, can charge you an extra facility fee because they're considered a hospital facility. So she used to get physical therapy at one place north of Charlotte, wanted to be a little closer home, so came closer home, not at the hospital, miles away from the hospital, and yet they charged her $200 some more as a hospital facility fee. So you want to watch out for that type of thing. So it's pretty huge. Sign
Now,
up.
my insurance covered it,
Your insurance,
but
I'm
you
sure
don't know
somebody
that
pays
when
for
you're,
it.
you don't know that when you
Yeah, that's
have your appointment.
So you want to sign up for public insurance if you qualify. Check the specifics of your care to make sure you're covered. So you really got to, and if you're uninsured, remember you can get a cost estimate. Financial assistance. You want to ask, you can be kind of a curmudgeon about this. You can ask them for line items, every cost for every service, prescription, or treatment. There's a book out there about hospital billing. It says never pay the first bill. So you can really go over it with a fine tooth comb. Check for double billing. You can negotiate with the hospital. This is perhaps the most important part of this slide. Do not pay medical bills with a credit card ever. Once you pay a medical bill with a credit card, it's no longer medical debt, it's credit card debt. So that takes you out of the group of people who can get assistance with medical debt. You now have credit card debt. Now, kind of shockingly, some hospitals encourage people and even partner with credit card companies to have you put your debt on a credit card, but it's not good.
So what do you do when you ask them for the itemized bill and they just keep blowing you off? I've done that in the past, and I've also tried to negotiate, and they just.
There should be a hospital ombudsman or someone like that you can escalate the issue to.
I know that happened to me, and if I know what I'm talking about, I can't imagine that somebody that doesn't would know even how to do that. And I did try to do all that, and they just never would follow through. And then you can make call after call after call, and after
They wear
that,
you
you
down.
just get tired.
Yes,
You don't
that's
do
what
that.
yes.
That's what they want you to do, I suppose.
I don't have an answer to how to escalate it. Maybe that book, never paid the first bill.
Yeah.
But
I don't know, I was just wondering if you had any insight on
do
that.
not. Try to qualify for charity care, dispute your bill if inadequate. Don't ignore it. Some people just put their head in the sand. So I want to highlight a couple of nonprofits here that are really helpful. This is called $4. Federal law requires nonprofit hospitals to offer free or discounted care for eligible patients, but it's not easy. It's not easy to navigate that and figure out if you're eligible for financial assistance. $4 will help you, and you can get some financial assistance even if you have insurance. So $4 is a great organization. This is one that I really want to highlight here and encourage people to donate to if you wish. And some churches have large church-wide programs that work with undue medical debt. Some small municipalities do, some hospitals do. As part of the North Carolina Debt Relief Program, hospitals will be partnering with undue medical debt to find and relieve medical debt for their patients. So this is interesting. It was founded in 2014 by a couple of guys who were debt collectors who decided that they wanted to help those in need. And the idea was simple: buy up large bundles of delinquent medical debt. It gets sold at pennies on the dollar. but instead of pursuing patients to pay it, you pay it off. And so they've paid off about $15 billion in medical debt for almost 10 million people. So a very good organization that I wish there was no need for them. I wish we had no medical debt, but they do very, very good work. So all that is to say, we're at many crossroads in this country right now, but we're particularly at a crossroad on what type of healthcare we want to have as Americans in this country and what kind do we deserve. I sit here as someone who firmly believes that healthcare is a human right, that it ought to be available to everyone, not just healthcare, but affordable, high quality healthcare for everyone in the United States. Right now, we're taking the other fork in the road. We're about to eliminate health insurance for 16 million people, and just go a little bit further to say the fact that this not extending the enhanced ACA tax credits and the everything that's being done with Medicaid, the work requirements, all that is an attack on the ACA. They are out to reverse Medicaid expansion throughout the United States and to dismantle the ACA. So that's 16 million people is all a reversal of that. And medical debt will increase, and there will be that death and a lot of suffering if we go in that direction. Unfortunately, we're at this crossroads. And most of us think that's not the way it should be in the United States, but the devil's in the details. We disagree on how we should get to universal healthcare. So most Americans believe that ensuring healthcare coverage is the government's responsibility. But what that looks like is where we get you get some disagreements. I'm going to tell you what we think at Physicians for a National Health Program in my organization, Healthcare Justice North Carolina. We think we already have a program that works for seniors in the United States. And if we improved it and expand it to everyone in the United States, that would provide universal health care. So Medicare, which 60 years old this year, signed into law in 1965. It provides health care for seniors in the United States, was transformative when it was signed into law in the 60s. At that time, seniors were the poorest demographic in the country. They suffered from the greatest poverty rate of anyone, and it lifted seniors out of poverty and extended their lifespan of seniors. So it was truly transformative. Not perfect. You got to pay 20% as 20% co-pay on Medicare. It doesn't include traditional Medicare, does not include vision, hearing. You have to get a drug plan. But I want to be clear, I'm talking about an improved version of Medicare for all that would cover all that. All medically necessary care, no co-pays, deductibles, or premiums, no supplemental insurance. There'd be a simplified payment design. The person you're paying is the federal government, and it is paid not through co-pays, premiums, or deductibles, but through a progressive taxation based on your ability to pay. You're paying for it now. You're paying premiums and deductibles and co-pays, even though you're paying for it now. So the overhead for Medicare is about 2%, the administrative overhead. The administrative overhead for commercial health insurance is somewhere between 15 and 18%. So there is money to be saved if we were to switch to Medicare for all. This is commercial insurance have these narrow networks of hospitals and physicians, high premiums, and prior authorizations to denial, the bane of physicians' existence. You have to get a prior authorization to be able to get that MRI that your patient needs. All ways that commercial insurance companies can be more profitable by delay and denial of care.
And I hear that one of the big issues is 57% of Americans who have good health care are afraid they're going to come after that's when I read the polling, yeah, there's 16 million, don't come after mine.
Yeah, I mean, some of that depends on, you know, I'll digress here and talk a little bit about Medicare Advantage, which is a commercial health insurance version of Medicare. And it is wonderful insurance unless you get sick. Once you get sick, that's where the narrow networks of doctors, you know, come in. Or if I want to go to a specialty cancer clinic or go to the Mayo Clinic, or go to Sloan Kettering for my cancer, you can't do that. The network's narrow. If I need skilled nursing care after I come out of the hospital or rehab, that's limited. So there's only a couple of ways commercial insurance companies can make money. They can either charge you more or give less care. And they're just doing their commercial thing, which is to be profitable. Profit in healthcare doesn't really work. So some people are, yes, very happy with their health insurance plan. Most of those people have never gone through an extended chronic illness that required skilled nursing care afterwards and rehab and things like that. When you talk to people like that, it's a whole different thing. So, yeah. So folks like that may be more amenable, rather than a big jump to Medicare for all would be something called the public option, where people could, now, I don't want to get too far into the weeds here, but that still leaves the fox in the hen house. That still leaves commercial insurance companies. And what commercial insurance companies do is, we call it cherry picking and lemon dropping. They try to keep the healthiest patients and offload the sickest patients. So they would offload their sickest patients to Medicare, to improve Medicare for all, and keep the healthier patients on their commercial health insurance. And that's what they do with Medicare Advantage is, improve Medicare for all, would free choice of any hospital or physician, all drugs paid for, lifelong coverage. And not to belabor point, but fully covered through progressive taxation. Everybody in, and we have the saying, everybody in, nobody out. Choice, we live and die on the hill of choice in America. I want choice. This preserves choice. Patients have free choice. Go to any hospital, any physician. And no one is denied due to pre-existing conditions. So how can we afford this thing? Good golly. 95% of households will actually pay less in taxes, or what you would call Medicare premiums now, than they currently pay in their premiums, co-pays, and prescriptions, and will have full comprehensive coverage free at the point of care.
What's
So-
the time frame? This sounds like a dream, kind of. I mean, you know, is this a 3-year, 5-year?
It's about a 5-year roll-in period. I'll show you that there are some links to actually review the law. So obviously there would be a dismantling of the health insurance industry. That's not a huge amount of job loss. That's well within the yearly churn of jobs in the United States, with people losing jobs and gaining jobs. There'd be retraining for people in the health insurance industry. There'd be more people insured, so there'd be jobs for them. But there's about a 5-year kind of phase-in period with this. There'd be some new expense. With all that savings, you'd save about $425 billion. And there'd be drug negotiations, device negotiations. Most Americans actually support Medicare for all. There's an April 2020 poll, 69% of registered voters support this. Obviously, more Democrats than Republicans. Young Americans are all for it. An old poll, 56% of physicians support Medicare for all. To be clear, I think most physicians would support the improved version of Medicare. There's lots of things right now with the current Medicare plan that frustrate physicians, but it would have to be improved Medicare. And most physicians' salaries would not go down. Perhaps some of the more higher paid specialists might see a small dip in their salary. Most physicians' salaries would not go down. So you want to know more about this. So this is the Medicare for All Act of 2025. There's a House version, Senate version. They're essentially identical to the 2023 versions. And you can either look at the fact sheet, which is pretty simple, or delve into the whole law. So only 2 of our representatives in North Carolina are co-sponsors of this, Alma Adams and Valerie Fouché, signed on. If I think we all probably are here in Alma's district, right? If you're not, call your congressperson and tell them to become a co-sponsor of this. Thank you. Are you a member of Healthcare Justice?
No.
You want me? I'm gonna give you my card. I'll give you my card.
I'm 100% certain that Dr. Lakin is working to recruit me.
Oh, yeah. Well, there you go.
Sure.
So how do we help move it forward and help people to?
And contacting your legislators works. I like to think that the whole reason Tom Tillis has left the Senate is we had a phone barrage of him telling, about Medicaid cuts, and we called him every 5 minutes during working hours for a week. We just blew up his phone lines. Not me, but all the Medicare for All Coalition in North Carolina. So they will listen to you. Phone calls are great to do. Storytelling is important. All the statistics I just showed, you're gonna leave here tonight remembering those personal stories. The statistics, you'll just go, I don't know, there's a bunch of people who don't have health. But you'll remember, personal stories are the most important. Just doing this, coming into churches, talking to people in church, because this morally, ethically, we look at this and go, this isn't right. This isn't consistent with my faith. So church, the youth, I hate to, dump everything on the youth. Well, they'll fix it. We have a new medical school in town. We have got a chapter of Physicians for a National Health Program. We just started with students in the new medical school. They are fired up. They now understand the brokenness of the healthcare system they're going to be working in. Partnering with other groups. We partner with labor. The labor movement is really behind universal health care because they're having their health care whittled away as well. The health care that unions fight so hard for, a lot of these unions, once you retire, they're trying to shift you into Medicare Advantage rather than paying for a Medicare supplement. So it's a surprising group. You wouldn't think union members would be in favor of universal health care because the unions supply. But think of it, if employers don't want to be in the health insurance business. Do you want to be in the health insurance business, Frank? No one should. So the idea is, Frank doesn't have to pay your health insurance. Maybe he can pay you more if you don't, So that's the hopes with this. So it's talking to people, personal stories, calling legislators. This is going to be inch by inch, though. So
When I was in 2017, I had a health crisis and had a lot of medical debt. My daughter was probably in elementary school at the time. And she was trying to understand how it goes. She said, so Mom, are you telling me that when we're sick, we have to pay money to get well? Like, it was so foreign
from the mouth of a
to
child.
her little mind to say, that just doesn't even make sense. And I use that runs back and forth in my mind. She's now in college and she's considering getting into the medical fields, and I don't know, maybe her generation can help.
Like any social justice work, you get involved in the work that's in front of you. We need our free clinics. We need our federally qualified clinics. We need Medicist for free med. We need Caring to help. But that work is all important. But sometimes you have to look up and go, why is it like this?
Right.
So Frank,
Why is it? And look upstream and go, oh, that's why, because it was built like that.
Yeah.
So that's where we are in this. Now, a lot of us, I work at a free clinic. A lot of us, donate our time and things like that. But we're trying to do the upstream work so that people stop falling in the river and drown.
Yeah.
So.
And it's everybody.
It is everybody.